Hello, everybody. I am Dr. Steve Johnson, and welcome to Theories of Addiction. We're already in week 3, so this is the question and answer period for any questions that you may have over the topics for this week. And if you remember, the main topic for both lectures, and we have the recordings on Tuesday and Thursday that are shown on Facebook. The topic is psychopathology, substance use disorders, and co-occurring disorders. And so there were a number of questions, not quite as many, and some of them don't have, the responses won't be as long as they were for the first couple of weeks, but we will give them due consideration. So thank you all. I hope the course is going really well for you, and that I know carving out time to get on Facebook and watch those videos can be a little challenging. But if you look, if you want to see them, you can always go to my YouTube channel, which is REBT Education and Training. And I have a playlist for the Theories of Addictions course. And so at your leisure, you can go through and watch all of the lectures there as recorded, all of the question and answer periods, and even some of the free kind of workshops that I will be doing throughout this particular semester. But let's jump into the questions. The first question is, I understand that in the past, mental and emotional disorders were called primary, and that the substance use disorders were called secondary diagnoses. But even today, don't we treat the mental and emotional disorders first and the substance use disorders second? Excellent question. The old model for treating dual diagnosis, or a substance use disorder with a mental and emotional disorder or disorders, was to first treat the addiction and then treat the the mental and emotional disorder. The logic was that until the addiction to the substance is cleared up, we wouldn't have an accurate picture of what the mental or emotional state is of the individual, and we wouldn't get a good read on the mental or emotional disorder. We tend not to think that way anymore, although and this is directly related to your question, there are still many addiction centers or treatment centers in the United States that will hold to that view, but certainly not most of them. Most of them realize that treating the mental and emotional disorder and the substance use disorder simultaneously is probably more warranted. Let's look at why. Let's say an individual has a pretty difficult case of generalized anxiety disorder, one of the common anxiety disorders. And because they're so anxious, they gravitate toward alcohol or taking benzodiazepines for the anxiety, and end up addicted to alcohol or benzos or both. And so if we treated the substance use disorder first, and that kind of got cleared up, the individual would still have the raw anxiety from the generalized anxiety disorder, which drove them toward the addiction anyway. So it's probably better, and each case is slightly different, to treat them simultaneously. Lisa Najavitz, who chairs a couple of the groups in Division 12 of the American Psychological Association that looks at evidence-based treatments for particular conditions, chairs the one on PTSD or trauma disorders. And one of the things that she found, she developed a model called Seeking Safety for PTSD and Substance Use Disorders. She found that clients really like to have both disorders treated simultaneously, and seemed to report that they did better in that way. So Yeah, there are those places that do treat the substance use disorder first and then the mental emotional disorder, but those are becoming less frequent. The second question is, in reality, doesn't a substance use disorder always co-occur with other mental and emotional disorders? The short answer is frequently, but not necessarily. It happens so frequently that I see why someone would ask that, because when we look at the percentages, and if you remember the lecture, particularly the first or second lecture this week, I was pointing out the frequency of individuals with particular mental and emotional disorders that also have a substance use disorder or vice versa. And so, while there are mental and emotional disorders that predispose someone to, to develop a substance use disorder, it is not a necessary link. We see it commonly, but it's not a necessary link. So you can't assume that. You're always going to have to see, and if we do thorough intake and mental status exam, we would look for the possibility of multiple diagnoses. So good question. The third is, are you saying that community health centers are not helpful? Community mental health centers are not helpful. I know what part of the lecture you're referring to, because I did say that in the United States, when we began to close the psychiatric hospitals, many of those individuals were released into the general population, and we referred to community mental health centers. Part of the problem was that those individuals that had really serious mental and emotional disorders, thought disorders, etc., that once they were released may have been more susceptible to taking street drugs, right, and becoming addicted. Plus, if there wasn't regular follow-up, then the individual may not make appointments and drop off. And then we see both the addiction and the mental and emotional disorders actually increasing. I don't see it as the fault of the community mental health centers, although it would be really important for each of them to, and I know sometimes it's difficult to have the funds for this, is to really, really follow up on those individuals and try to make sure that they get in for an appointment. And then even if you do that, there's no guarantee that those clients would do that. So it did create a problem when we closed the psychiatric hospitals down and the individuals were released. But we're doing the best we can in trying to develop more mental health centers, community mental health centers. Some of the statistics, though, are rather dire. When we find out that only 7% of those with a dual diagnosis get treated, that means 93% of individuals who have a dual diagnosis are getting any kind of treatment. And if you think about it, in some addictions where the cravings are so bad and the individual has great difficulty working, holding down a job, then they may resort to crime, stealing, whatever. So that creates some other social problems too. It is a complicated issue and one that needs ongoing investigation of what are the best ways to do that, which is part of what we looked at with the public health model. Good question, thanks so much. Question number 4 was, is treatment of a substance use disorder complicated by the fact that, except for alcohol, typically an individual with a substance use disorder is more often than not addicted to another substance? Absolutely. You're absolutely correct. Polysubstance use is more the norm than the exception. Rarely do we see an individual, except for alcohol, come in with one addiction to one substance, but not use another substance too. That's quite common. And it's even more complicated than that, because if we have an individual with polysubstance use, and we see that a large percentage of clients with substance use disorder also have a mental and emotional disorder, and sometimes more than one mental or emotional disorder, then we have very complicated treatment situation. So for example, let's say that we have an individual with post-traumatic stress disorder, right? And so they begin to self-medicate, for anxiety. They become addicted to benzos and alcohol or whatever. And then if they have chronic pain, another condition, then that might have been complicated by an addiction to opiates. So we have a really difficult combination of addictions there. Or an individual with a personality disorder may also have a mood disorder. So we're having to treat two different conditions there. And we know that with both mood disorders and personality disorders, the incidence of the abuse of substances can be elevated, so that we may have an even more complicated treatment system there. So you're absolutely right. It's a complicated, very complicated picture sometimes when we're doing that. And that's why I think we need more and more mental health practitioners who specialize in addictions, because it is a very much needed field given the elevation of the number of addictions and the presence and the dual diagnosis. Okay, again, thanks again. All of these really great questions. Thank you guys. The fifth question was, given the high incidence of personality disorders or PTSD and so forth, to develop a substance use disorder, should a practitioner ask about drug use for clients if there is a mental and emotional disorder? Well, absolutely. That is bottom line in when we do an assessment on any client. A safe practice for all practitioners is to be thorough and to check for the presence of a mental and emotional disorder, as well as a substance use disorder and physical disorders too. If they have those, we need to try to find out and have that added to our notes. So because that may complicate the picture too, although we may not be treating the medical condition. So this is part, I think, of an adequate intake assessment that we do that. And there's one other part to that. Not only do we get all the information, do we get the information from the client, but often with someone with a substance use disorder and some mental and emotional disorders, we would want some collaborative sources of information. Collaborative sources would be if the individual is hospitalized, or they've seen another therapist, then we would have them sign a release of information form so that we could take a look at what's in those files. Also, if they give us permission for us to talk to family members, friends, etc., then they can be collateral sources of valuable information that may help us in our treatment of those of the client. So, excellent question again. The sixth question was, in diagnosing a mental and emotional disorder and a substance use disorder, how reliable is a client with a substance use disorder to give us an accurate picture of their drug use or their mental status? And again, this is quite a good question. And as I said, one of the ways that we do this is to not only talk to that individual, and get as much of a history as we can, but there are other things that we do, including the collateral sources. Let me just give an example. One of the things that we often do is to give instruments, and some of those instruments can be instruments that look at general drug use, as well as measures of mood or anxiety, etc. So we can use those instruments as additional sources of information for clients. Also, on the intake form where they write, we will look at that, look at what they put on the intake form, and often we will follow up asking questions where we want more elaboration on certain points. We also want a very systematic interview where we're really going through looking at, developing a differential diagnosis and then narrowing that down to the more accurate diagnosis, or at least provisional diagnoses. Okay, so we're going to have that, and then of course many therapists are going to do a mental status exam or mini mental status exam, and those will give us a clear picture of their cognitive state, such as memory, and any number of issues. So if the mental status exam does show some problems with memory or cognition, etc., then, or even some delusions or hallucinations, then we will take that into account in terms of assessing the narrative that we are receiving, and we'll really try to get some collateral sources to the degree that we can. So again, excellent question. Just a couple of more questions. The second question was, how can I get reliable information about psychotherapies that are evidence-based for treating substance use disorders or co-occurring disorders, mental emotional disorders? Again, an excellent question. And I don't have time to go into all of that, but with just a little work, you can get some really reliable information. One way, of course, and that we hope that in graduate school, individuals have learned how to do this, is how to read outcome studies that are published in reputable journals, that are refereed, not going to newspapers or blogs or the internet or YouTube or TikTok, although there are good things on those. But typically we want some outcome studies from reliable peer-reviewed refereed journals, okay? So that would be one way, generally not social media. The other one is to look at, in that same vein, is to look at meta-analyses. This would be a research paper that looks at the outcomes of multiple forms of outcome studies, and compiles that data and summarizes the findings across a bunch of outcome studies, which gives us some really valuable information. So sometimes that's my starting point, is to look for meta-analyses and then zero in on individual outcome studies. One place that you can get some very reliable information, which I mentioned a little bit earlier, is to go to the website of Division 12 of the American Psychological Association, which looks at evidence-based treatments. It's a great resource. Go to that website. You can press on treatment, and you'll have a list of diagnoses, of conditions. You click on that, and it will give you a list of the evidence-based treatments. And sometimes it always will grade the strength of the treatment, that it says high research support, moderate research support, or in some conditions, for example, in PTSD, one kind of treatment, it says it is potentially harmful and probably try to refrain from using that. So you'll get the grade of the strength of the study, the outcomes. And so you can use that information to zero in. Why would that be important? Well, that will give you a clear view of the evidence-based treatment models for any particular substance use or a mental emotional disorder. And this comes in handy is if you have a client and for some reason they're moving out of town, or you're taking some time away from the practice whatsoever, then you can make an accurate referral based upon the practitioners and what kind of models they practice in the area in which the client lives. Another great place is to look at SAMHSA. SAMHSA really specializes in addictive disorders. And so if you look at that, mental health and addiction disorders, SAMHSA has some great information on evidence-based models. Another place I go to is the Cochrane Report. The Cochrane Report looks at the the assesses the strength and reliability of particular kinds of treatment models. Okay, so these are some starting point of some good places to get some reliable information on what tends to work and for whom. Okay, and of course, keep in mind that we always need to discuss with the client, because the client will have definite views about it. For example, there tend to be two categories of treatments for post-traumatic stress disorder, but one is what we call exposure-based therapies, and the other is called presence-centered form of therapies. Some clients don't want exposure forms of therapy because they've heard that it can be emotionally painful to imaginatively try to relive a trauma, whereas others would prefer that rather than just having some interventions that they use when they get physiologically aroused or triggered. So that may help us decide what evidence-based model we would use with a particular kind of preference on the part of the client. The last question is, if I am a psychotherapist and not a psychiatrist, and so I can't prescribe medications, which is generally true, why is it important to know about the medications? I think there are several good reasons why it's important. In fact, at the university where I teach, at Columbia International University, if you're going for the Masters in Addiction Counseling, which is the program that I direct, we have a psychopharmacology course that looks at medications that are used for mental and emotional disorders and substance use disorders. And I think there are some good reasons why it's important for you to know that, even if you're not a prescriber. Typically, a psychiatrist or another kind of physician who also prescribes psychotropic meds may not see the client really frequently. They're more spaced. The timed space is much greater than for a psychotherapist. It's not uncommon for a psychotherapist to see somebody once a week or several times a month, which probably wouldn't be the case with a psychiatrist. Some would. And so I think it is when we are working with the client who's been put on a medication and we're aware of what that the side effects of medications are, et cetera, then we would be aware of what might be going on. And if there's a problem, then we might suggest that the client talk to the psychiatrist or the prescriber, or if they've signed a release of information form, then I can go, or you could talk to them about what you see with a client. And I think what we're doing is, if someone has a psychiatrist and a psychologist and even some other, and maybe they're in a support group, these are multiple safety nets for individuals. And so I think the psychiatrist is a safety net, the psychotherapist is a safety net, and we should be in collaboration and work together for the good of the client and share information to the degree that the client will permit us to do that. I think another good reason is if the symptoms become worse, let's say they're prescribed a medication and the symptoms of the client gets worse, then we need to take action as soon as we could to make sure that the symptoms don't increase or the client gets worse as a result of the medication, which may just not be a good fit. And so it is really helpful for us to know the potential side effects of the medication then. And I think sometimes, a third way I think is sometimes the client, because the psychotherapist sees the client more frequently, we may have a greater chance of them revealing information that is really important for the psychiatrist to know, because sometimes the psychiatrist has really short sessions with an individual, or more brief sessions than we typically do. Because in one of the states where I practice, we had one psychiatrist for every 9,000 individuals. And so there were just not enough psychiatrists to go around. And so the psychiatrists were doing the best they could in prescribing, but that meant so they weren't working themselves to death, that those sessions would be shorter. And that would really be helpful for us to collaborate with the psychiatrist or the prescribing physician or medical personnel. So I thank you very much for attending today. I hope you found that helpful. Just keep in mind that many of you I know are very interested in how we use cognitive behavioral therapy in treating substance use disorders. And I will be giving a whole week to that topic, where first we'll be looking at the behavioral model, and that has wonderful things that we can do in terms of treatment. And then we'll spend a whole week on cognitive behavioral models. So if that's why you really were looking at the theories of addiction class, live in hope. We will get there. But thanks again, and keep the questions coming in, and have a great day. Bye-bye.